Okay, good afternoon, everybody. Thanks so much, everyone, for coming to today's session. Really looking forward to three and a half presentations and a great discussion afterwards. My name is Gib Clark. I am the coordinator of the Wilson Center's Global Health Initiative, as well as the program associate on the Environmental Change and Security Program, both of which are excited to be co-sponsoring today's event, along with the Interagency Gender Working Group, who we're very thankful to for support and help and everything else with today's event. A little bit about the center for those of you who haven't been here. Before we get started, please bear with me, those of you who have heard this several times. But the Wilson Center was formed in 1968 as the formal living memorial to President Wilson, as he was the only president to have earned a PhD, for better or for worse, and as he was the president of Princeton. The idea was to bring together the worlds of academia and the world of policy. And so that's what we and about 20 other programs here at the center aim to do. Today's session, we're looking at sexual violence against minors. As you all know, for this issue to be adequately addressed, we need to have a good handle on the data. We need to understand the scope of this violence, the consequences of it, and we need to know how to translate the data and research into effective policies and programs. And today's speakers, the lineup we have, I think, are just the right people to talk about these and a whole bunch of other relevant issues. Our first presentation will be from Kiersten Stewart. She is the Director of Public Policy and Advocacy at the Family Violence Prevention Fund. Before that, she was Chief of Staff to Representative Maurice Hinchey, handling legislative work around women's issues, HIV/AIDS, civil rights, immigration, and poverty. And next we'll hear from Jim Mercy. He is the Special Advisor for Strategic Directions of the Division of Violence Prevention in the National Center for Injury Prevention at the CDC. For the past 2 decades, he has played a fundamental role in developing the public health approach to violence, and he has conducted and overseen numerous studies of the epidemiology of youth suicide, family violence, homicide, and firearm injuries. And then our last presentation will be from Jama Gulaid. He is the country representative for UNICEF in Swaziland. He is also the acting UN resident coordinator there. And he has served UNICEF in a variety of capacities as epidemiologist in Nigeria, on the global team of advisors on health in New York, as the director of the health and nutrition teams in Ghana, and as a global advisor on policy and partnerships. But before we get to those presentations, we're going to hear some opening comments about this issue, why it's important, from Michal Avni. She is a gender advisor in USAID's Office of Population and Reproductive Health, and she is the coordinator of the Interagency Gender Working Group. Before joining USAID, she worked as a researcher in maternal health and gender issues. For all 4 of these people, I've cut their bios very, very short, and there's much more information available at the door. So I'll stop there. Just saying one last thing, which is when we get to the Q&A, please wait for a microphone to come around to you. You'll notice there's a camera in the back, which is filming this and being broadcast live and later in archived form via webcast. So we want folks to know who you are and what your question is. So let's get started with Michal.
Thank you. I'm going to be very brief because I think our speakers have a lot more to say. That's very, very important. On behalf of the Interagency Gender Working Group, I would like to join Gib Clark and the Woodrow Wilson Center in welcoming you to this afternoon's event. I see many familiar faces, but some new ones as well, so I'm just going to say a few words about the Interagency Gender Working Group, or IGWG. It is a network of non-governmental organizations, USAID, and cooperating agencies or implementing partners. The IGWG is coordinated by the Bureau for Global Health, and it is dedicated to promoting gender integration in order to improve family planning, reproductive health, and HIV outcomes. If you would like more information about the Interagency Gender Working Group, we have some web cards outside on the table, which will direct you to our website and provide you with information on how to subscribe to our listserv and also some other relevant materials that you might be interested in. Today's event is focused on sexual violence against minors, and by that I mean sexual violence against children and youth under the age of 18. Sexual violence against minors in developing countries is not a rare event, nor is it a new phenomenon. Quite to the contrary, those working with children and youth and many reproductive health practitioners will tell you that they encounter the problem and its consequences regularly. But sexual violence against minors has long been neglected by the international health and development community. Although it's been getting some public attention recently, for example, the op-ed piece in the New York Times that's outside, as well as the recent article in The Lancet, it is an issue that, for the most part, still is kept under wraps, and it's kept under wraps for a number of very significant reasons. First and foremost, probably, because it affects perhaps one of the most vulnerable and disenfranchised populations, children who are unable to advocate for themselves and speak up. Another very complicated factor about sexual violence against minors is that it is shrouded in shame and stigma, and it is, for that reason, very difficult to speak out, to speak openly about. Sexual violence against minors also poses many ethical, logistical, and methodological challenges for data collection and for programmatic implementation, particularly in low-resource settings. So for these reasons, most of what we know about sexual violence against minors, its prevalence, risk factors, consequences, and programmatic responses, comes from research and data collected primarily in developed countries. We do know that it is a grave public health and human rights problem. We know it affects child health, both physical and mental. It is connected with unintended pregnancy, risk for unsafe abortion, and the full range of reproductive health issues that we are concerned with in our community, including HIV and other STIs. So in short, sexual violence against minors is a global health issue, and it must be addressed in the context of development. We really hope that today's event will shed some light on this problem and provide some information and evidence that we do have from developing countries. And it will begin a dialogue about how to include sexual violence against minors in our larger agenda for international health and development. So again, thank you for coming and thank you for participating in this discussion that will ensue after the presentation.
Yep. Okay. Okay.
Thank you so much for that introduction, and I am truly honored to be on a panel with such esteemed colleagues. I almost dare not say colleagues, because these two really truly are some of the world's greatest researchers on this subject matter. So you are quite lucky to have them here. And again, my name is Kiersten Stewart. I'm with the Family Violence Prevention Fund. We are a national nonprofit organization based here in the U.S. We were founded initially in San Francisco in 1980. Is when we actually incorporated. We began, like many U.S.-based organizations, focusing principally on domestic violence, but have really expanded that focus, particularly given that we're begin from a public health and as well as a social justice and rights perspective, to look at violence against all women, children, men, and families and communities. And have, because we focus primarily on prevention, we also have largely stopped distinguishing between domestic violence, dating violence, sexual violence, child abuse, child sexual abuse. We really do try to look at sort of common strategies to prevent and end all forms of violence against women and children. We have done some international work as an organization, though principally we are a U.S.-based organization. So I'm going to try to draw some links both in terms of what we know, in terms of some of the very specific repro health outcomes, which we do have some stronger data, at least that I'm familiar with here in the U.S. But also we do have some strong data from the World Health Organization. I know my colleagues here are going to go into great detail on some very specific data, so I'm going to leave most of that to them and focus instead on some of the consequences of violence from a health perspective, and again, particularly repro health. And I'm also going to look at, or hopefully prompt some questions and conversations, some things to think about as you analyze data and think about these issues. So the first thing I'd really like to talk a little bit about is definitions. And you're going to, when we talk about definitions of child sexual abuse, depending on who you talk to, and depending on what data set you're looking at, you may be looking at very different things. There are some very common things that we know, and I've sort of highlighted some of those, which is that, and this is, again, across both the U.S. context, when we look at the World Health Organization reports, when we look at Latin America and Caribbean, when we look at Africa, when we look across the world, we find some pretty strong consistencies. Most sexual violence, particularly against children, is committed by people known to the victim. Most sexual violence overall is committed against children, with the majority being young women. I always question a little bit that data, particularly around sexual violence of boys, because I think as much as sexual violence of girls is underreported and stigmatized, I think sexual abuse of boys is even more so. So as I get to my things to think about, I don't want to underestimate violence against boys as well. It's often committed within the context of intimate partner violence, and so and again, it's when we sort of look at age and developmental levels of young people, we need to understand when we're looking at something different and when we're looking at something very similar to sort of our traditional IPV, right? Because we often fail to look at the rates of sexual violence within the context of intimate partner violence. Sometimes we distinguish those, and sometimes we do a good job of keeping them together and trying to understand how they go together. When it's perpetrated within the context of marriage, that's even trickier, right? Particularly when we look at adolescents and even young girls who are forced into marriage at very young ages, or adolescents who are within marriage and have very few rights and power within marriage to negotiate safe sex or even to negotiate sex at all. That, from our perspective, is still very much child sexual abuse. Adolescent sexual violence, though I know doesn't necessarily fit the traditional definition of child sexual abuse. I think we also, and we've really come to this in our work, more than anything, you need to think about what the issues, or from our perspective, what the issue of force is, and where power lies. And that ultimately, from our perspective, is sort of the key understanding about child sexual abuse in many ways, which is who has the power and why, and then what do they choose to do with that power. I think many of us have this very clear definition in our minds of what rape is, but most sexual violence, as I said, doesn't really fit that definition. And so let's keep those things in mind, and we can talk, I think, a little bit more about that when we get into the discussion. Organizationally, we've really moved to this notion of sexual and reproductive coercion to try to get at what might be considered that gray area between what would be rape, as is commonly defined, and what would be choice to have sex, which isn't, if anybody was that girl, wouldn't necessarily deem that a choice. So I'm going to flip back a little bit between some of the U.S. data and some of the international data as well. On the one hand, I don't want to focus just on the U.S., but also I don't want to exclude the U.S., because somehow this notion that we've fixed this is really problematic, because we're actually not one of the better countries in terms of our rates of child sexual abuse, as well as in terms of our response to it. We know that 1 in 4 women are victims. We know that 1 in 5 teen girls report it. And again, depending on the data set, sometimes you get sexual violence, sometimes you get physical and sexual violence together. You also notice that between 1 in 4 and 1 in 5, again, depending on what study you look at, Americans report being victims of child sexual abuse. And I think this is much less well known. We have tremendous rates of sexual violence in this country, up to 500 women a day, according to some of the studies with the highest levels, but still many hundreds of women and girls and some boys a day are raped. Majority of victims are under 18, about half are under 12. And like the international data, the overwhelming percentage of perpetrators are known to the victim, often family members. Not always fathers or stepfathers. We're going to talk to that, but still very much people who are in the house with the child and someone that they often trust and know. Again, some of the evidence in terms of, and again, we sort of pulled from different studies, and I think we have more up-to-date studies now from across different countries, depending on DHS macro, CDC does some of the studies. So you're looking anywhere from 10 to 60% in some cases. I also went ahead and I pulled from Jennifer Wagman's paper that I think maybe some of you have seen. She has some very specific data on Uganda. From the recent DHS survey, 21% of all 15 to 19-year-old Ugandan women and 36% of married 15 to 19-year-olds have ever experienced sexual violence. And so the numbers are quite high. And again, I think it's important to understand marriage is actually a risk factor for sexual violence in some situations. Not necessarily very young children, but very young children as well. I also want to thank Ian Askew from Pop Council. He's going to be presenting more of this data this afternoon. So again, I didn't want to spend too much time on it, but to give you a perspective of some of the smaller, both qualitative and quantitative studies, again, across Zambia, South Africa, Malawi, you're looking overwhelmingly at violence against sexual violence, among sexual violence, a lot of sexual violence against children and young people. Violence and reproductive health. They are very, very strongly linked, and I'm guessing this is a room full of experts, so I will go through this somewhat quickly again to give folks time for conversation. But I think it's very important to understand the link between violence and reproductive health outcomes. We talk about unplanned pregnancy. We talk about, Michal talked already about at risk for abortion. We talk about maternal mortality, poor pregnancy outcomes, low birth weight babies, as well as HIV. And then it's also important to understand how the violence, how they loop back, right? So it is both that when you have an unplanned pregnancy, when you have HIV, you may in fact be at risk for greater violence. Simultaneously, that it may go the other way as well, right? Adolescent IPV and unintended pregnancy. Again, here in the U.S., we have data showing that about adolescent girls who are in abusive relationships were 4 to 6 times more likely to become pregnant than non-abused girls. Women who are sexually abused as children are twice as likely to have unprotected sex when compared to women who did not experience child sexual abuse. And I think that's important when we talk about what are some of the reproductive health consequences of child sexual abuse. Because often what we think about is that, if she was raped, is there an unplanned pregnancy as a result of that rape? Well, that's often not how child sexual abuse plays out in terms of reproductive health consequences. It is often the additional risk factors that lead to these poor reproductive health outcomes potentially down the road. So you need to look at what are both the immediate consequences of any given particular act of sexual violence, but also what are all of the health consequences down the road and how those interact together. And that's, I look to my research colleagues to untangle a lot of that because I think we're still figuring that out. Again, we talk about condom use as one of the places where we've really identified where child sexual abuse both contributes to increased risky behavior, but also among boys and girls. And I think that that's an important distinction. Often we talk about, are there more multiple sexual partners? Do you initiate sex early? We're going to talk a little bit about who's initiating sex. And what... and whether or not you're using a condom during any particular sexual intercourse. Within marriage, you actually have less power, right, to negotiate condom use in many situations. And so that's why in some situations you see more HIV within marriage. I'll skip that U.S. stat. The one thing I will say is that among low-income women here within the U.S., we've really started looking at this notion of birth control sabotage, which I think was something new to us in recent research, which is that partners who are very intentionally getting their wives, and most often girlfriends, or girls pregnant, who may not necessarily be a particular partner, and what's going on there, and that they are very intentionally lying about birth control, punching holes in condoms, throwing pills down the toilet, things like that. And that women do report who are victims of, and again, we talk about physical, emotional, IPV. We view sexual violence within the context when we're talking about relationship violence within IPV. And again, some adolescents, that's this really blurry line, right? So we've set this definition of 18 and younger, but that's not really how most people, young people's lives exist, right? They may start having relationships at 14, and we might call that child sexual abuse. They may be with a different partner at 16. It may very well be the consequences of that early behavior or the same behavior at 18 or 19. And again, that's not necessarily the same thing as what happens when a stepfather molests a child at 6, but we need to understand this violence in the context of the whole continuum. What are some of the consequences of this abuse? I touched on it earlier. When you look at 2/3 of pregnant adolescent females who disclose childhood sexual abuse and are raped prior to their first pregnancy, and abused pregnant teens initiated sex 2 years earlier than non-abused pregnant teens. In the Felitti study, so this is the Adverse Childhood Experiences study, and this was a study that Dr. Felitti, who was actually a Kaiser healthcare obesity researcher, pioneered with, ultimately with Rob Anda from the CDC. This was an obesity researcher who was having great success actually helping patients lose weight. And then he was finding that his patients that were having the most success losing weight were dropping out of the study. And he said, well, that doesn't make a whole lot of sense, right? It seems like the people who are having success would be the ones that would want to stick with it. And so he read somewhere that age of sexual debut was related to weight. And so he tells this wonderful story, and it's not so wonderful, but quite telling, of the first time he asked a patient, he's an obesity researcher, he begins every conversation with, how much did you weigh when? And he talks about, he was going to start asking these questions about sexual debut, and he asked a young woman who had been in his program, how much did you weigh at first sexual experience? And she said 40 pounds. And he said, before he caught himself, and he's like, oh, I didn't mean to ask that. And then he says that was his aha moment, right? Because that's when he all of a sudden stopped himself and said, 40 pounds? I must have heard you wrong. And she said, no, it was my dad. And that's when he went, oh my goodness, I have been missing something tremendous here. And a lot of people, he started finding these, up 22% of patients in a Kaiser health plan in San Diego, who these were employed, educated, had good health care coverage, a largely middle-class population, and he found that between 20 and 25% of them have experienced childhood sexual abuse, and that it was directly related to their success in weight loss programs. And so he partnered actually with Rob Anda to try to add some methodological rigor to the work. And it's really shown us some of the true health consequences of childhood sexual abuse and the ways in which it clusters with other things like substance abuse, like smoking. We also looking at some of the Jennifer Wegman's research, again, cross-culturally, risk of coercive sex was found to increase with younger age at first intercourse, consistent. She's looking at the Rakai study in Uganda, other indicators of risky sexual behavior, and a range of adverse reproductive health outcomes. Again, same data. Young women who were reported forced first sex were significantly more likely to report at least one genital tract symptom and more likely to report both unwanted and mistimed pregnancies. Forced sex was less likely to use contraception, less likely to use specific condoms at last sex, and that more likely to have HIV. Also looking at rapid repeat pregnancy is one of the other outcomes. Again, it's something we talk a lot about, which is the desire to plan and space pregnancies from a public health perspective. When you've had physical abuse, you're more than likely to have a rapid repeat pregnancy because the sexual violence happens within the context of that physical abuse. Again, when we look at HIV, I'm going to, more than a third of adolescent girls, again, this was a U.S.-based sample, tested for STIs and HIV have experienced IPV. We know that when people are showing up a lot to get testing, it's usually as an indicator that they have experienced sexual violence or sexual coercion, right? It's their way of often help seeking. Girls who are abused by male partners more likely to become infected with an STI, HIV, because of the sexual violence within that context, more likely to have HIV, more likely to have an STI. Yeah, I want to talk a little bit about this. I think I've already touched on it. That marriage is not necessarily as protective. It's the ways in which child sexual abuse cause increases in risk behaviors, more likely sexual partners, more likely not to use condoms, relationship to drugs and alcohol. I want to talk just a little bit again, you're going to hear a lot more data from the experts on that. I want to talk a little bit about the causes of sexual violence, and do realize that I come at this from an advocacy perspective. And a lot of it's about power. And I think sometimes we forget that. It's not about sex, though it's never, we can't say that it's never about sex either, right? So it's often about who has the power to demand and expect sex and force themselves when necessary. But often you don't have to force yourself when it's a 9-year-old that trusts you, right? And you don't have to force yourself when it's a 14-year-old who knows that she has no power to say no. And that we wouldn't necessarily call that rape, but that's not choice. Okay, and from our perspective, we need to understand that if we're going to talk about prevention and intervention. A percentage of it is, I think, about trauma and mental illness, again, particularly when we talk about some younger children. And I think that, what's happened in Darfur and particularly, in DRC and Congo most recently, I think has, even among those who do sexual violence work and have for decades, I think all of us, and I'll look to my colleagues, are reconceptualizing what that is and what it represents. I mean, we've seen violence in conflict. We saw it in Bosnia, obviously. We saw it in Rwanda. I think what's happening in the DRC, many folks who have been there would say it really is an act of genocide. It is the intentional effort to destroy and decimate a population of people from the face of the earth. And I don't want to say that that's the majority of sexual violence out there, but we would argue we need to call it what it is and understand sexual violence as a security issue and as a conflict issue. So again, just to summarize, and I think I've said this repeatedly, we need to be able to parse out what the sexual violence is, but we don't want to separate it from a whole continuum of violence against women and children. The other thing that we would say, and this is often these aren't hopeful conversations, but I do want to end on a slightly hopeful note, which is we believe that most violence against women and children is learned, and hence it can be unlearned and it can be never learned. And we are about prevention, and prevention is hard, right? It's always hard to prove what didn't happen because of what you did. So we would encourage folks to consider a couple of principles when they think about the prevention and addressing and ultimately ending violence against children. First and foremost, that children themselves are not responsible. I think often a lot of our strategies, they're helping kids protect themselves. I think we would push back against that conceptualization and say, it's not simply about arming children with good touch, bad touch, or self-defense skills, or don't walk at night, or don't need to go to the bathroom, or don't need to get water. I mean, these are not realistic from our perspective, again, as advocates. This is a community responsibility, and this is a national responsibility to protect children. Consequences are so severe, and particularly, I think, in resource-poor settings, that the need to focus on prevention is even greater, right? This isn't going to end because we lock up every person that's ever done it and put them in jail and spend the next 20 years building jails every place where there aren't enough jails to hold these people. So it is about ending impunity. That's important, but it is first and foremost about prevention. There aren't excuses for it. I mean, and I think that that's one of the challenges. We want to look at understanding it, why it happens, where it happens, who does it, who doesn't, and why. And so I think it's still very important to say poverty is not an excuse for this, and it's not an explanation. It may increase risk factors in some places. It may contribute to perpetration for some men in some instances, but it's not why childhood sexual abuse happens. Similarly with alcohol abuse, I think a lot of folks look at some of the alcohol data and they'll see increased frequency, they'll see increased severity around both physical and sexual violence associated with alcohol. But alcohol abuse does not cause violence. It rarely is there no violence and then alcohol use and then new violence. That happens in some places. I'm not, again, saying it never happens, but far more it's a power and control, and that the alcohol itself may increase frequency and severity. I think transactional sex and sexual coercion need to be recognized, as I said, as existing on this continuum of abuse. No girl or boy, for that matter, chooses to trade sex for food when they're as a life goal. None of us grow up wanting that for ourselves. None of us grow up wanting that for our children. So to say that people want to survive is not a bad thing, and that doesn't make them at fault. And from our perspective, again, as advocates, I wouldn't say that makes them complicit, right? And yet people will say, well, that's a choice. So it's not sexual abuse, it's not forced sex, it's a choice that they're making, and therefore it doesn't fall into this category of things we need to worry about. And again, we would sort of push back against that assumption. Again, there are good programs around the world, and I'm running out of time, so I'm going to just quickly go through a few of them. This was a domestic violence program. I stole this from one of my favorite people in the world, and that's Mary Ellsberg, from a program she's worked on largely in Latin America. But then that was one story about from what a man said, and then these are some of a couple of programs that are out there that really are about changing norms. And helping around violence, and how do we engage the health sector specifically to do some of the positive programs to prevent and address violence. One of the things that we found is critically important in terms of all treatment of physical and sexual abuse victims is this recognition that healthcare providers themselves are often victims. And I think we didn't fully understand the extent to which we have to deal with providers' own experiences of victimization or perpetration, for that matter, when we asked them to implement all of our good programs. And that when we look at sort of where programs are working and not working, I think we often and when we talk about issues of fidelity, right? I mean, I think that's the technical language more. Well, is there fidelity to the program? Well, when we go in and actually do the work, and a provider doing a checklist and asking a question and not making eye contact, and clearly there's no responsiveness and no help for that victim if she does disclose, is going to get a very different level of disclosure. And I think one of the things that's really important around that issue is this work that Mary Ellsberg and Claudia Garcia Moreno and folks at WHO did around the multi-country study from about 4 years ago now. And when they looked specifically at the issue of child sexual abuse, they thought about different ways to ask the question. And I think one of the really important things is that they did ask, and I think they got rates. What did they? I mean, they found in their work rates of about, I think, highest rate of 21% in Namibia in terms of those under 15 who'd experienced childhood sexual abuse, and that 10 to 15 of those settings, over 5% of women had reported their first sexual experience was forced, and that the younger the age, again, consistent with other research, the more likely it was forced. But what they did that I think was so smart and something we can all learn from is they asked the initial question, right? And then they recognized that a lot of women, and particularly girls, are not necessarily going to be comfortable answering that question. And so they asked it again anonymously. And they allowed people to just sort of mark a smiley face or a frowny, or a frown face. And they allowed them to report that anonymously, not necessarily tied to their actual survey. And what they, lo and behold, found is much higher rates of response when they allowed people to respond anonymously. So it speaks to the point of needing to ask the question multiple times in multiple settings, and not necessarily get too tied to specific prevalence data. To the extent that you want to look at trends, it's important, but to the extent to think that the difference is 21% versus 22%, knowing the reporting bias, it's probably not, from our perspective, where we should be spending most of our time. Again, some great programs out there that are specifically working with men on prevention to change norms and attitudes around violence against women. I'm going to end with my favorite one, and that's Program H down in Brazil. Gary Barker has presented a lot on this, and I know has spoken here with Andrew Levesque on this program. This is a program down in Brazil that has specifically shown that changing norms through public education and groups with young men, you can reduce violence, you can reduce HIV, and you can reduce unplanned pregnancy by working around male norms. Fantastic program. And then my last thought, because I'm never going to miss a chance to be in a room with so many people who are smart and are good researchers. So the questions that I feel as an advocate that I still don't have enough to do good work around, and I wish I knew more. Men and perpetration. Almost all of our research looks at victimization. It's understandable why. But if we're going to really start changing behavior, we need to focus more on men. We need to focus on interventions that work. we can't just wait for the randomized control gold standard, 20 years down the road. Maybe we'll have some ideas. And I don't mean to suggest that these folks are necessarily advocating that at all. But I do know that often it's a real challenge to get substantial research dollars behind this work. And I think often the methodologies can be used sometimes to say, oh, well, we don't have proven data, so we don't do anything. No, we do data and we do something. And then we try to do both as quickly as we can. Ending violence is going to be, it's a process. It's not one program, right? And we talk about cultural competence and cultural specificity, and it's as much about how you engage with the community in that process of figuring out their own solutions, what's going to work in their community. And so we need to think about that as we do interventions and as we try to scale up interventions. And finally, my favorite question, which is, who are the guys that despite everything are still your heroes, right? Who, despite being victimized themselves, despite growing up in a home with very rigid gender norms, despite being a child soldier who was forced to perpetrate violence, how did they still step away from that situation and not continue that behavior? And how do they then teach that behavior to the next generation? And I think we don't know as much about the good guys, and that is the majority, right? And so we need to spend more time with them as well. And I will stop there. Thank you.
You're just going to do the presentation right now. Okay, thanks so much. We're going to just jump right into Jim's presentation.
Let's see here. Do you know how to get to it, Kiersten?
See, down one. There you go. That one with the arrow. Yeah.
Okay. Well, thank you very much, Kiersten. That's a great lead-in to my talk. And I also want to say how honored I am to be on the panel with Kiersten and Jama. Really, I admire both of them for their work, and particularly Jama. Jama and I first met 20 years ago and actually haven't seen each other since, so it's great to be here with him. I'm going to tell you about mostly the data from the study of sexual violence against female children in Swaziland. I want to give you something, a little bit of background first, and that is that this study and the response based on the data is serving as a model for a broad collaboration between CDC, UNICEF, UNIFEM, UNAIDS, UNFDP, and that's being championed by the Clinton Global Initiative to expand this and conduct similar surveys and responses in other countries developing countries around the world. So as you see our talks unfold, you can be thinking about how we can build and improve upon this. I want to start by just making some acknowledgments, particularly of two people. A lot of people contributed to the success of this study and the use of the data to really influence action. But the person that was the real vision behind it was Jama. He was the one who called CDC and asked for to collaborate in some sort of research around this issue, and he's the one that kept the collaboration together. One thing I know, I learn again and again, but that great research, great programs are always based on strong collaboration. And this was particularly strong. It brought together CDC's sort of technical expertise with UNICEF's passion for addressing issues of children, as well as their contacts on the ground and their great collaborative spirit. The other person I need to acknowledge, else I get in trouble, is my wife, Avid Reza, who was on the CDC team that worked with UNICEF to conduct the survey. Kiersten already talked about this. This is just a conceptual model of how this experience of child sexual violence, also violence more generally against children, contributes to a series of cascading impairments that can lead to disease and early death. Jack Shonkoff, he's one of the leading experts on child development around the world always says that if you want to change the world, you need to start by making it a better place for kids. And I think you can begin to see, based on the information Kiersten provided and some of the additional information I'll provide, why that is very much the case. Here are a number of the health impacts of sexual violence. The evidence is stronger for linking child sexual abuse to some of them than others, but you can see it's a range of health risk behaviors. Kiersten mentioned many of these, as well as diseases and injuries and mental health and well-being, issues of mental health and well-being. But I want to be clear, it's also serious diseases. If exposure to violence as a child, sexual violence as a child, contributes to smoking, for example, smoking is a risk factor for cancer and heart disease. That leads to premature mortality. So you can see the connection between these various types of health issues. These are data from a World Health Organization study that was done as part of their global burden of disease effort to look at the relationship and try to estimate the impact of child sexual abuse on the burden of mental illness around the world. In order to do that, they accumulated studies from every region of the world, all the studies on the prevalence of child sexual abuse, studies on linking child sexual abuse to mental health outcomes, and they came up with these results. These are the prevalences of child sexual abuse based on the studies they reviewed for different regions. They divided Africa into high mortality countries and very high mortality countries, and you can see that the prevalence is much higher in very high mortality countries. But you can see in each of these regions, with one exception, the prevalence of child sexual abuse is at least twice or almost twice as high or more as it is among males. The one exception is the Latin America Caribbean region. I don't know enough about this study to know if how many studies they relied on and how reliable those data are for that region, but typically you find much higher prevalences of this among females than males. But here's the interesting thing to me. They took these data then, combined this information, and estimated for the world now. I just showed you the prevalences for the developing regions, but they did this for the whole world. The contribution of child sexual abuse, the fraction of mental health disorders that child sexual abuse accounts for in females and males. And you can see that for females, 7 to 8% of the depression among females they attribute to exposure to child sexual abuse. Same with alcohol use dependence, drug use, panic disorder 13%, PTSD 33%, suicide attempts 11%. And the contributions are lesser for males, as we would expect. But even if these estimates are twice as high as they should be, this is a tremendous impact across mental illness, and it does not even take into account the impacts on reproductive health, on chronic disease, on the other things that we've already mentioned. What's the mechanism for this? Very important. This is really new discoveries in neurosciences and child development tell us that exposure to toxic stress, to really severe stress, such as that would occur when a child is being sexually abused, actually impair the development of brain cells, actually impair cell tissue in a way that can lead to poor health, actually can damage the brain's stress response system and contribute to premature aging, and all of those range of health behaviors that we saw. Now, this is true. The brain is still, parts of the brain, the prefrontal cortex, is still plastic through adolescence and into early adulthood. So it's not just very young children that are affected by these types of stresses, but adolescents as well. Well, with that as background, let's go into the Swaziland study. We really started out in this study to be broader than just sexual violence against children. It was a study of violence against children. I'm only going to highlight the results on sexual violence, though. We wanted to describe the magnitude of the problem, describe some of the health consequences associated with these exposures, identify potential risk and protective factors, and then use these data to guide programs and policies to prevent the violence. Jama, in his wisdom, accumulated many stakeholders to be involved in this at the outset, and that was critically important for helping to set the stage for the data to be used. How many of these studies and data do we hear about that don't get used and contribute to action and policies? We can't let the data sit in the shelf, particularly these data. And so involving these stakeholders was critical to what transpired afterwards. As Kiersten pointed out in her talk, when we're talking about sexual violence, and in this study too, we looked at a range of behaviors, not just rape, the one people associate with being the most severe, but also attempted sexual acts, abusive sexual contact, non-contact sexual abuse. So we looked at a range of behaviors. The methodology was a national household survey. It was a two-stage cluster sample survey, which means we first selected what's called randomly selected enumeration areas around Swaziland. These are like census tracts. And then within those enumeration areas, we randomly selected households to go into and identify if there was an eligible respondent to interview. We would have liked to also have interviewed boys in this survey. Unfortunately, financial restrictions forced us to restrict it to females, and that was a choice, conscious choice, because other data suggested they're at greater risk. But we also did want to understand this among boys. Unfortunately, weren't able to do so. Very important issue in this type of survey is to protecting the respondents. We took a number of steps to do that. One thing, we did not disclose the purpose of this study to the village leaders or heads of households as we gained access to the respondents. We told them it was a health survey. Only the respondent knew the actual content of the survey and agreed to participate based on that knowledge. We conducted interviews in private and had a predefined procedure for handling interruptions. The interviewer would switch to demographic questions if somebody walked in the room, for example. We provided a list of services to every respondent. We also had a service agency contact respondents who were upset or expressed a desire to get help. If they expressed that desire while going through the survey, then we had the service agency contact them after the survey to see if they needed help or further services. And the survey was anonymous, no identifiers linking the data with the respondents. So the results, we visited 1,900 households. There was eligible respondents, 13 to 24-year-old females, and 1,300 of them. We completed interviews in 1,244, which gave us a 96% response rate. That's like getting 1,550 out of 1,600 in the SATs. You know, that's really great. So, just looking at some of the basic demographic characteristics, a little over 50% were in the 18 to 24-year age range, and the rest were 13 to 17-year-olds. We chose this age range, 13 to 24. Ideally, we'd want to interview just children, 0 to 18, right? But for many reasons, you can't interview very young children. Ethical reasons, plus very young children don't understand the questions. So what we're doing in the survey is estimating childhood exposure to sexual violence, sort of retrospectively asking these 13 to 24-year-olds about their experience as children. And you can also see that 85% of the respondents were from rural areas. We asked about their description of the first sexual intercourse, and here are the results of that. Over half were either persuaded, tricked, forced, or raped in their first experience of sexual intercourse. 44% had the first experience willingly. The majority of those that did not have that experience willingly were persuaded, followed by tricked, forced, and then raped. Now, this slide really gets at the heart of the study. Really, the main estimate we wanted to arrive at, and it's the proportion of these 13, 24-year-olds who reported being sexually abused as children. So 33% of the response reported, or a third of the response reported any type of sexual violence as a child. Almost 5% reported forced intercourse, around 9% coerced intercourse, 19% attempted unwanted intercourse, 14% unwanted touching, and 1.3% forced touching of perpetrator. So you can see the range of behaviors we examined, and you can see how some behaviors are more common than others. But I don't think you should attach severity to these behaviors. I think it really depends on the experience. Something that we may think is less severe may have very severe consequences for the respondent, for the victim. This shows the percentages, the perpetrators of these instances of child victimization, child sexual victimization. 32% was a man or a boy from the neighborhood. 26% was a husband or boyfriend, followed by other male relatives and strangers. One thing that we were surprised by, because when we first started this study, we were very interested in sexual abuse by teachers. Actually, we had just 2.7% of these victims reported being victimized by teachers. That often gets a lot of attention, but these other relationships appear to be more important, at least based on this study. We're in the midst of an examination of the risk and protective factors. So these are preliminary, but one thing that seems to be appearing is that a close relationship with the mother is protective. Currently not attending school, as you might imagine, being a risk factor. Exposure to emotional abuse, not surprising that sexual abuse probably occurs in household contexts that are chaotic or have a lot of other issues going on. And having ever witnessed someone being sexually assaulted is a risk factor. So something about being in context, high-risk context, seems to be going on here. We looked at the relationship to various health issues, the association, and adjusting for other possible co-occurring factors. I just want to highlight a couple of these things. The only one that's not even borderline significant is cigarette use. I don't think cigarette use is very prevalent in Swaziland, but that's contrary to other studies which find this association. But two I want to point out is the odds for sexually transmitted diseases. This suggests that that girls who experienced child sexual abuse were 3.7 times more likely to have an STD than those who didn't, including HIV. Also, unwanted pregnancy, almost girls who experienced child sexual abuse were almost 3 times more likely to have an unwanted pregnancy, backing up the data that Kiersten talked about. So just like in other studies, just like consistent with the other research, a lot of health outcomes associated with these exposures. Conclusions, the fact that a third of female children experience sexual violence makes this a huge problem. It doesn't put it out of line with the type of prevalences we see in other countries, even in our own country. But nevertheless, I think that type of exposure, and if you have these health consequences that we're talking about, imagine what the cost of this is to society, of these types of exposures. Part of the problem in addressing this issue, and again, Kiersten referred to this, is that it's embedded so much within close relationships and the culture, I should say, the nature of power and control relationships within communities, and so it makes it very difficult to try to change, to try to prevent, but something that we can't let up on. So men and boys that are in close relationship to these girls are the primary problem in terms of perpetrating this abuse. Sort of taking off on those preliminary results and risk factors, I think the lack of supervision of young girls may be a problem. because those not close to their mothers or those who are not in school were at greater risk, and this idea of sort of chaotic home environments that somehow contribute to it. These are some of the ideas that are emerging. We were not able to look at cultural issues, the role of social norms in contributing to, as a risk factor, or other broader societal factors, but they, in this study, but they probably are very important as well. And I already mentioned the exposure to the impact on different health problems. So there's a great collaboration, and here's one of the little children from Swaziland, and I'm happy to turn it over to Jama.
Thank you very much. It's really a pleasure to be here. Swaziland is such a small place. People either fly over it, or if you get close, you come to Johannesburg. So thank you very much for your interest in Swaziland, and I also thank you for the invitation to this meeting. In my previous life, we used to work very closely with US AID, at initially the Africa Bureau, and then afterwards with the Global Bureau on child survival activities. And in those days, the most we had to do was immunize the children. Measles was on our mind. Diarrhea was on our mind. But almost 2 decades later, I've gone around different places in my assignments with UNICEF, and I find out that sometimes you think that measles was bad, and then you get other problems that you never really anticipated or thought about. In a moment or two, I think you will get to see a little bit of some of the issues that I'm talking about. But before I also begin, I want to tell you something about my first name. How many of you are familiar with the Journal of American Medical Association? Okay. This is way back when I was working with Jim at CDC in Atlanta. And one day I went to the to the library in Clifton Road at CDC. In those days, when you request a literature search, you didn't have your computer you went to the library, and the librarians will give you the printout. So I went there and I said, hi, can I have some material to pick up from here. And she said, what's your name? I told her Jama. Then she said, yes, nice to meet you. My name is Lancet. So I said, okay, good to meet you, Lancet. But now can I have the material? And she did. She gave me the material. I will cover a number of areas. I think a little bit of background just to put it in a context. And I thought I will also give you a little bit of a follow-up to the recommendations of the study. I think Jim and Kiersten have really talked about a number of the other areas in terms of evidence and data. But the task that was given to me was to talk a little bit about what do you do with findings of studies. So I came with 2 ideas. One was to give you a slide presentation. The other one was just to give you show you a video of 20 minutes. But I couldn't decide which one. So since we don't have enough time, I'll just show you some of the slides. The other one probably be more lively because you see the children acting, doing things, community leaders, and so many other players who really don't have much knowledge of research, but have an important role to play in translating research into practice. So I will focus on the key recommendations of the study, and hopefully in the interest of time, then I will be able to tell you a little bit more about what has happened since we completed the study and we got the first results in 2 years ago. In terms of challenges, before we get to the challenges, Swaziland has got about 1 million population, 1.12. And out of the 1.12, you have 130,000 children who are orphans because they lost their parents from HIV or HIV-related diseases. And the number is likely to double. So whatever else that's happening, you can understand the context of vulnerability in that environment. The other major challenges are HIV, poverty, and food insecurity. Ironically, Swaziland is classified as a lower middle income country, yet 69% of the population live below the poverty level. Clearly, the resources are unevenly distributed. Swaziland also has not been able to produce its own food to meet its needs in the last 2 decades. And there are a number of theories about why this is happening. One of them is that the droughts, there are recurrent droughts in the last, have been recurrent droughts in the last 2 decades. Another theory is that HIV is contributing to the food insecurity because either young people of productive years of life either died early or are too sick to be able to produce. But there's also another factor that is related to land tenure and use. And a good part of the land is used for cash crops, sugarcane, forestry product, and citrus. But also Swaziland has a number of things working in its favor. It is a stable country, and I think that counts a lot when we're talking about violence. And you can reach any part of the country at any time of the year. No snowstorms, no windstorms, no Sahara Desert problems, no rivers that you cannot cross. And the society is really a homogeneous society. Everybody speaks the same language. They're all related. 1/3 of the people have the last name Dlamini. So if you want to take a guess and you just say, oh, Mr. or Miss Dlamini, then you're almost 1/3 right. One language, and it's quite easy that way. And the other really advantage that we have is that we know the problem now, the problem of violence, and we also know a lot about the epidemic that we're dealing with. There's a lot of data. There are many countries in Africa, the developing world, that have not done census in 3 decades, and they're extrapolating data from 30 years ago. Swaziland is sort of following the inspiration from the United States, I think. Every 10 years we do a census, and it's working out. But the data on violence is really has been a tremendous asset for us. The other problem is the HIV/AIDS. As you can, Swaziland has really the unenviable reputation as being the country with the highest HIV prevalence rate. For countries for which population-based data is available, and there is a cluster of them in this slide, you would see that Swaziland has got the highest prevalence rate among women in productive years of life. 47% of the child mortality rate is related to HIV. That's why I'm a little nostalgic about measles, because you can go and vaccinate a child about measles from measles. But HIV, it's a tough battle. So this is really the context. If you look at this graph, also a couple of points of interest is just the variability. This is the prevalence rate for all persons over the age of 2 years. And you'd see that the exposure first comes through delivery and maybe immediately after, breastfeeding probably. And there's about 5%. Boys and girls almost evenly at risk almost. And then after you pass that window of birth, then it comes down to about 3%. And then from there onwards, things go different ways for boys and girls. And you can see that for the girls, By the time they are 15 to 19, the rates jump from 3 to 10%. The next cohort, 2024, is 38, and 25, 29, 49%. Just imagine, 49% of young women in that age cohort are HIV positive in Swaziland. For boys, the prevalence rate varies. It doesn't peak as early. It peaks about 5 years or so later. By the time they are 30 to 34, they're almost about the same rate, 46%. And part of the theory is that men in the older age groups are interacting and having relationships with the younger girls at a much earlier age. And as Jim pointed out, some of these encounters are also violent, and that complicates things. So I think enough preamble. Now I would have to report back, because I'm sure Jim is taking notes, watching what we have done in the last 2 years. This slide shows a summary of the recommendations of the study. And altogether, I think we had about 14 recommendations. 3 of them were for immediate term, in the immediate term, and I think about 6 were in the for the medium term, and 5 for the long term. Just in case I run out of time, I'm just going to give you the score so that you have some idea. To be conservative, I think we have followed up and implemented 57% of the recommendations. Putting all together the long term, although I think we still have more time to spare for some of the long term, but there's some sense of urgency when you are working in Swaziland and some of these issues are happening. But if you count the areas that are marked, the bullet points that are marked with the open dots, those are the activities that we have started but we haven't finished, and you can't really finish them right away. Then that moves our average to a score of 71%. But let me now talk about what the content is for these areas, one at a time. The first recommendation was the dissemination of the findings of the study locally. And this is really, really the heart of the matter. I say the heart of the matter because discussions about sexuality, even in the context of an HIV/AIDS epidemic, is not an easy one. But when you bring in violence on top of that, it is even more difficult to talk about it. So you have to do 2 things. You have to share information, which is what we normally would do in the studies and so on. But also the other part of it is you have to present it in certain ways. And if you are in a traditional society, and that's where I grew up in such environments, who says it, when you say it, how it's said, all of this really matter. They won't read Lancet. I'm very, very excited about some of the really attention that the publications have generated. But for other people that we like just to work with and collaborate, do not read scientific journals. So it really matters a lot in how you do. So the first thing what we did was to have the study disseminated, the findings of the report, the descriptive analysis. And CDC did a fantastic job. 3-4 months after the study was completed, we had the report in our hands. And then immediately we organized the dissemination meeting. So, and in a traditional environment, the more senior, the more responsibility you have, whether it is in the church hierarchy or in the traditional hierarchy or in the government hierarchy, it matters. So we want to look for people who would advocate and support the dissemination, and that was really the critical point. So we had the Deputy Prime Minister launch the dissemination of the findings. Very powerful woman, very committed, and she didn't really mince words. She said it. And hearing it, coming it from a woman, a deputy prime minister, mattered a lot more than anything that Jim and I could ever do. And I think that, and then the media was there and everybody was there. Then after that, we decided then to go and work with the major stakeholders. So we had separate briefings. We call all the parliamentarians. There are two houses. We have two houses too, Senate and Parliament, House of Parliament, and 65 members in the House in the Parliament, and the rest of them are senators. And we had separate briefings for them. And we went with the study, and we have to explain things and go through a lot of these, together with the other partners. We worked also with the church groups separately. Again, we had separate meetings with the teachers, and then we brought together the government, senior government officials, technocrats, and then we also had separate meetings with the teachers, with the police, with the school children, and then we have another sort of cadre of staff called Community Child Protectors. This group really didn't exist in the formal structure or the traditional structure in the past, but because of the new circumstances in Swaziland, people recognize there is a need, because of the vulnerability of children, to have somebody in the community that is that's identifiable, that people can relate to, so that if anything should happen, whether the child didn't eat, whether the child is beaten, whether the child is sexually abused, the child can go to that person and report and say, this is my problem, and that person will know what to do. Either they'll take you to the chief, or take you to the school, or take you to the police station, or whatever. They are not paid, but they are trained, and we've been working with them since we helped establish this group. There are 12,000 of them. And in a small country, 12,000 is a large contingent. Very powerful group. The other groups that we also work with are the caregivers. There are centers where the children who are orphans come together, and basically they provide supervision, food, and also a little bit of adult supervision so that children can play in a safe environment with each other. And those also have to be trained, and they have to tell them in certain ways what has happened, what the findings are, and what they can do as well. The other element that was requested, that we need to establish a lead agency, identify a lead agency to coordinate the prevention and the response effort. In a small country, again, there are limitations. You cannot really establish new bodies or new institutions every time you have a new initiative. So what we tried to do was just to look for a place where the leadership will also come from, and rather than create a new group or an office, have that group office take responsibility, an existing office take responsibility for it. Fortunately, the children's issues in the last 2.5 years have been under the Deputy Prime Minister's office. And you have an office called the Children's Coordination Unit, and then the Department of Social Welfare. And until just recently, there have been only 2 social workers in Swaziland, you could imagine. So that gives you some sense of the capacity. I think you could even do a lot better with the community health workers and the volunteers because of the numbers and the commitment, than try and use the framework of social workers in a country like that. But there is now the Office of the Deputy Prime Minister is taking the lead on all matters related to children. But once we brought this under to their attention, we had a change of government, but the new government also is very, very supportive and sympathetic. So the new Deputy Prime Minister is now overseeing all issues related to children, including violence. And I'll tell you a little bit more in a moment. The third element was the further analysis of the data. I think here is where CDC brought the expertise and excellent work. I think they've done the analysis for us, and you're familiar with some of these. But as I said, we did a different kind of unconventional analysis, in terms of translating that information to what may be marketable locally. But in terms of really the scientific way, CDC is our resource, and we're very, very grateful for that. The second part relates to the medium-term recommendations, the public information campaign. Once we got the clearance from national level, the media had it their field day, and they covered the stories, and it was announced, and it was on television. Then we have briefed all these different stakeholders. Then we can just go to different parts of the country and organize systematically some campaigns. And ever since 2007, we have had a yearly campaign, and we have conducted those with children in every region of the country. Children have a weekly radio program, and that program is really helping a lot. It's run by Children for Children, newspaper articles, and so on. The strengthening of the legal action, that's one of the areas where we have gained much ground. Swaziland now has approved, since the study was completed, the Sexual Offence Domestic Violence Bill is in Parliament. It had its second reading last week in Parliament, and we are very hopeful that it will be approved. There is a new legislation on trafficking and sexual exploitation of children that has passed Parliament last month. The first child-friendly court was established in the country, so that the legal teams can provide administer justice and in an environment that is more suitable. In the police, there are police stations or different parts of the country, and 76% of them now have child-friendly rooms where children who have abused and relatives can come in and receive counseling and sit with them. So the police are actually getting to do some of the work that we needed to be done. The information, integrating it into the school-based programs, the message has been incorporated into a number of the school-based interventions. Life skills program, the sports program, the peer education program, all of them are now reflect the interest and the importance and information from violence. The evidence-based intervention is a little harder, because we really don't have too many other studies that really give you an idea about if you do X, Y, and Z, although our colleagues from CDC have shared with us a number of studies that were done in other countries. But we are trying to use the school folks programs to try and promote the idea of safe school environments. Next to the safe school environments, really, it's just the safe homes and safe neighborhoods are the priorities for us. The National Plan of Action on Violence Prevention, we have an initial consultation on the development of a National Plan of Action, but we really don't have much progress to report in terms of providing shelter. It's very difficult for us with resource limitations and all of that. But in terms of counseling of victims, there are some preliminary efforts that are underway. The third category of areas for follow-up was capacity development. And this is really a tall order because it goes beyond just training somebody. You also have to talk about human resource, transport, equipment, spaces, all of this. Nevertheless, I will share with you a little bit of the things that we have done. And in police, as I mentioned, we have worked with them extensively, and really the police is one of the units that is doing an excellent job. The Ministry of Justice also doing very well. Those two departments, I think the Justice Department and the law enforcement agencies are way ahead in this respect. Ministry of Health still has a long way to go because they don't know how to provide services. They don't have even the equipment and materials to provide. Some of them even hesitate because they don't want to go to the court and appear in the court day after day as to provide evidence if the case has to come to trial. So we have difficulties in some of these areas. In terms of sharing experience with other countries, yes, a number of international conferences, one in Africa, in Nairobi, the third Global Congress in Brazil in 2008, And our executive director, when she first saw in UNICEF, when she first saw the findings of the study, said that I think I want to have all the reps in Africa. We were going to have a meeting. She said, I would like to have this study presented to them, and we presented to that audience. And Tanzania and Kenya are already planning to replicate the studies. The injury surveillance work, I think we have already done some groundwork there, and stakeholders, because you have to bring, this is surveillance that will bring together justice, education, health, civil society organizations, UN agencies, etc., together, and it's not an easy task, but we are on it. The communication strategy in terms of for social change, that is an extremely, probably one of the most difficult challenge. If we had a formula on how you change major behaviors or social transformation, we would have made a lot more progress on the HIV/AIDS front. But still, we will keep trying. I think just a few things here. What's happening in the education sector, school-based interventions, schools and the community collaboration is very important. The schools will not really do a whole lot by themselves unless there's supervision, and we have ensured that there is mechanism for supervision and oversight. There is a toll-free line that now is accessible to children that they can call in and report on cases. Unfortunately, it's only open between 9 to 5, Monday to Friday. And if you have only a landline, and that presents a lot of difficulties because violence does not occur only between 9 to 5, Monday through Friday. So we are working with the largest provider of cell phone services in Swaziland. And last week I met the director, and we are exploring a way in which to bridge the cell line with the crossover to the landline so that many more people can access it. There are a lot of sanctions now that are being promoted, and one good example is just this report. This is the second most senior official from the Ministry of Education. Teachers now are aware of it. Communities are aware of it. Everybody is aware of the difficulties, and although, as Jim pointed out, the teachers contribute to a small proportion of the overall burden of the problem, but they also work with the largest number of children in one place. And we thought that they should also provide a very good environment, and if we can make the school environment safer, and children are safer in staying in school, not dropping out and all of that, then maybe the carryover will be a lot easier than trying to change and transform the villages and the communities. In terms of conclusions, I think the study findings stimulated national dialogue on a very sensitive topic. We are now past the denial phase. In the past, I've talked to a number of people, and they will say to you, oh, no, this is just a sensational story in the newspapers. It's not real. But now that we have that, nobody questions that, including traditionalists, including some of the people who were really thinking that this is a foreign idea. And that's one of the first things you could do is to an idea to be labeled a foreign. So it's no longer foreign now. It's a local matter. The study provided the impetus for us to advocate vigorously for relevant legislation and policies. The children's policy was in a draft form for 5 years. After the study, and we advocated for it, it has a lot of protective elements, and it was passed this year. The experience of Swaziland also shows that a national study of this nature can be conducted to inform interventions and also to encourage other countries to replicate. I would also add my voice to what Jim said earlier, that violence prevention and control calls for broad partnerships. Every aspect of society and nearly every field of work must really be engaged in this. If not all, but at least the most. That is really very, very critical. The collaboration between CDC and UNICEF has really moved the agenda extremely forward. I will explain that one moment. UNICEF is good in doing work in the field and in global advocacy for children's issues. We're not really very good in research work. CDC is I won't have to tell you a lot more about CDC. You know CDC. Their reputation, their integrity, their research work, their capacity, and all of that. But you bring those two together, and then you have the research and the advocacy and the groundwork come together. And I think that's just only a portion of it. I think the other partners that are behind the scene, those that I've not mentioned here now, that are part of the partnership, the police, the communities, the volunteers, all of them really have a role to play. And we have tried to integrate some of these activities into the programs that are also traditional. And for the very first time, I don't know if you have heard about the Reed Dance in Swaziland. Every year there are several national events, and the maidens, these are unmarried women, come together and they perform a national dance. And this year there were 100,000 young women that came together in that forum. So we use that forum again to promote and disseminate findings about HIV and the risks, violence and the risks to young women and what they can do. This has only been possible because of working with some of these other traditional partners that have now come to accept it. So I think the partnership is great, and I appreciate the opportunity that you have given us to share with you some of the ideas about Swaziland. Siyabonga, as they say thank you in Swaziland.
Okay, well, thank you very much to all three of you. Before we jump into the Q&A and the discussion here, first just a reminder about microphones coming around, but then also Kiersten mentioned something about later this afternoon, and that is that for those of you interested, after a short break, probably about 15, 20 minutes, we're going to be coming back in here, and the Interagency Gender Working Group is going to be holding a follow-on meeting delving into some ethical considerations of research into this field, and a little bit more on translating this research into best practices. So with that, why don't we jump into the Q&A? Who wants to get us started? How about right here?
Hi, I'm Sarah Friedman, and I'm with ECPAT USA, which stands for End Child Prostitution and Trafficking. I have just amazed by all of this information and data, and it's really hard to absorb and will take a lot of thinking. But I have two questions, and one of them is a kind of concern. For Kiersten, with all the invisibility of this issue, there's one issue that's even more invisible that you didn't bring up at all in terms of the impact, and that's prostituted children. And I don't understand why it can't be part of this issue. It's certainly violence. The study, both in the U.S. and worldwide, and very little attention is paid to it. And with the studies that have been done, in the U.S. alone, 98% of adult sex workers were abused as children. I mean, it's an absolutely common practice that leads to that starts with violence and leads to more. And the other is for Jama. And I've also worked at UNICEF for a long time. I'm really amazed at what you're able to do, and it really shows how working holistically, that if you have the will to do it, it can be done. But I have two questions. One is, did you bring the CRC into this process at all? Because it's such a good opportunity to do that. That's its Convention on the Rights of the Child. And secondly, poor as it is, Swaziland is a kind of homogeneous country. So how would this work in much larger, more diverse countries such as South Africa and many others? So thank you.
Okay, let's get one more question up here. Thanks.
Hi, is this on? Yeah? Okay. Gretchen Bachman from USAID, working with the Office of HIV/AIDS on orphans and vulnerable children issues. I have a question about the respondents of the survey in Swaziland and whether it was all household-based or there were any children, street children, children in orphanages, children in domestic work, for example, who may be even more vulnerable or the most vulnerable, whether they were part of the survey and whether they, since few are in school, whether they will be part of the response to the survey results. And thanks for sharing the results. It's a great study.
Okay, I think that's a little bit for everybody. Why don't we take a shot at those questions? They're always on.
Oh, okay. I'll go ahead and just answer the specific question about sexually exploited girls and specifically prostitution. Yes, absolutely agree that children being forced into prostitution is a form of child sexual abuse and sexual exploitation. I think you touch on one of the real divides right now, which is that our trafficking work is often completely separated. And that all prostitution is not trafficking, right? And so, well, I think that there's a lot of there's multiple views on that. And so, yes, I think it absolutely needs to be explored in terms of where it fits in. I think it's just simply that we tend to divide the trafficking issues and the forced prostitution issues from this, and it's problematic. So I appreciate you highlighting that.
Thank you very much for the two questions. Yeah, CRC. I think it's just only the question of phrasing it. If you go to a traditional society and you say that the violence against children or abuse is against the rights of the child, you may not really have the impact that you're looking for. At times, actually, it may even be counterproductive. It will be something very foreign. But if you say, okay, in your culture, in the traditional culture, before some of the urbanization, some of the other problems occurred, how did the culture deal with issues like this? Was it acceptable to have children abused or young women abused? They would say no. So at times what we do is we have learned the hard way that if you carry the flag of the CRC, with its name in it in foreign language, then it doesn't work very, very well in some settings. But even as we were discussing in the conceptual stage of the study, we said, do we look at this as a human rights issue or should we look at it as a public health issue? And we said, well, let's do the work first, and then we can bend it this way or bend it that way. So, but just to give you another angle to it, we're using the legislation, the findings of the study, to advocate for some of the comments that came from the CRC when Swaziland submitted its last report. One of them was the children's policy. Why don't you have a children's policy that provides protection and all of that? And we were having a hard time just to get that one done. So now we got that. The other way is that in the we're using this whole opportunity on an interest in legislation about children to push the other protocols, the optional protocols for the CRC. And next month, the Parliament has already promised us that they will pass them. They've already had some of the reviews. The various portfolio committees have looked at it. So I agree with you, but it's just only the language. The other part about the homogeneous one, I think it's a very valid question, but the only thing I can say is that you really need to know your society, your community. And I'm sure that in every society, even if it is diverse, there are levers, there are to pull, there are agents of change, there are groups that it may even turn out that a homogeneous society may even become, if they say no, then it becomes difficult to penetrate. Whereas South Africa, in a society like South Africa, very, very vibrant media houses, so many different channels, you may be even able to go much faster in other routes that we cannot go.
In terms of this study, I didn't mention limitations, but that's clearly one of them. If a child was not part of a household, they would not be captured by this survey. Although we did capture kids that were out of school or dropped out of school, we did not capture street kids or kids in orphanages, I don't think.
No, but there are only 2 orphanages in the whole country. So.
But there's as Jama was saying, there's few orphanages in
Registered or unregistered?
These are the only registered one. Yeah.
Okay, let's grab the question in the back there.
We better get off because I know I'm short. I'm Alberto Concha and I work here for the Pan American Health Organization in Washington. Nice to see you, Jim. I was very impressed for the three speakers and all the information you show. Again, show us how complex the problem is, not only of sexual violence but also violence in general. Very complex, and all the recommendations you have made down there in Swaziland shows how the complex of the problem is. But I was also impressed by Kiersten's first comment on the issue of development as a very important thing to tackle when we face violence. And later on, Jim mentioned the stories on the toxic stress that affect children's brain. And I was remembering the report of the Commission on Health Determinants of Health that was launched last year in October by WHO, in which one of the most important recommendations is to focus on early child development if we want to change things in society. And that was stressed by you too in your speech. So I was wondering, Jama, if all the programs you have, in all these recommendations, about 24, something like that, recommendations you are now implementing in your country to face this problem, which ones for you yourself are the most important that will bring the issue into solution? Because besides all the problems you presented, HIV, with almost 50% of women, 1 in 2 women suffering at the age of 30, 35, something like that, HIV, wow. That's a huge impression for everyone who wants to face this problem. So that's the first question for you. And last question for Jim, is the study is basically a survey, a household survey. Is there any complementary study on qualitative study that gives us more reason, like why this is happening? Actually, Kiersten mentioned that many men, as I think those who are here, are not sexual perpetrators. And the answer to your question, why so many men, the majority of men, we are not perpetrators of sexual violence, will be responded through complementing this study with qualitative analysis of the reasons of this type of problem. Thank you. Sorry for being so long.
Then we have we have 2 questions at the end, and then at the other end here. Thanks. And we'll get to you next.
Hi, Francisca Vigo-Walsh with Catholic Relief Services. I'm their SGBV advisor. Just a quick question on a technicality. I understand that when you conducted the survey, no one was informed of what the purpose of the survey was. But when you presented the findings at the community level, I'm interested in how you framed it so that there would be no references made immediately to the survey, and how you may have put in place mechanisms for protection of the respondents if there was indeed any connection made. Thank you.
Thank you, Pauline Muchina. Thank you very much for the presentations that you have given us. I hope that they will be available. The PowerPoint presentations will be available to us later. My question goes to Jama. Jama, you talked about the traditional leaders being involved in your work, and I was wondering whether the issue of child marriage is being addressed, especially given that the king, is one of the men who have married a child. And I'm just wondering what efforts are happening around that. And the second question is for the hotline that you're talking about. Do most people in Swaziland have access to phones or not? And are there other means of them reaching help other than through the phone? Thank you.
Okay, let's take a shot at these. Cover that.
Okay. Thank you again for your very, very important questions. I hope I don't have to choose. I don't want to disappoint you, but I hope I don't have to choose one intervention because I couldn't. Because we have to multitask and do a couple of things at the same time. HIV, do this one, do that one, but not too many that it becomes diluted in terms of focus. But I agree with you, the early child, and that's why for us, when there are very few social workers, we are betting a lot on the community-based interventions, where you have community structures, volunteers, you have grandparents who are looking after the children in Swaziland, a lot more than even some of the parents themselves. The question about how did you frame the question, and then in terms of during the dissemination, I think everybody knew that it was a study about violence, but it didn't say it was specific on sexual violence or so anything that comes out of it. But at the same time, also, we do a lot of work with the communities and we share the information about certain things. We bring a problem not by quoting specific, either articles, citations, and all of that. So you come in with a problem and say, look, there is a problem, and they know. And you come in with statistics also that are already generated from other sources. The community themselves are reporting on some of these episodes. So what the study does is just makes the case stronger, and it perhaps changes the quality of the dialogue and the debate, but not so much creates the entry point already come from many of the other things that are coming, information that is coming from the communities. I knew there was going to be some question that that touched on the children's age. It is a tough one for us. It's a tough one. Swaziland is not the only one, but also often we have a struggle in dealing with that issue. And we don't really have an answer for it yet. But the only answer we know is that we cannot really just stop because there is only one person who, with authority and power, that would marry, children officially when they are very young. So we haven't figured out exactly a good way to reconcile the convention again and that element. And Swaziland ratified the convention, and child marriage. But the age of marriage, the violence, the statutory laws actually do not differentiate between marrying very young and in the traditional way against what is the other one, and abuse and violence. But the things get very, very complicated because we have traditional law and we have got the Roman law as well. They are parallel. And once you go beyond the national level, you enter the territory of the sphere of the traditional culture. So if anybody is an expert in some of these areas and how we can reconcile, come and see me. We will travel together to Swaziland. I need your help.
In terms of other research, I'm a researcher at heart, so I could think of hundreds of studies. But I do agree qualitative research would be tremendously helpful in sort of giving a richer context for understanding these patterns that we see in the data. Also, I really think it would have been great if we could have afforded to have interviewed boys, because then you could ask them about direct questions about their endorsement of certain norms or things like that, and get a better understanding of the perpetration side of this issue, perhaps. And another issue that you're not able to really study well in a survey like this is trafficking, because the respondents aren't there, right? So that's difficult to get in this type of study. So there are other forms of research I think would be very important under ideal conditions to do on this issue. But we felt this was a place to start, to really get the basic understanding of the problem and its dimensions documented.
Yes. Yes, that is one of the benefits. Recently, somebody told me that Africa has more cell phones than North America. And it's just amazing how everybody, and it cuts both ways. Part of the problem is that the cell phone culture perpetuates the relationships, because those who are able to get it may even put you at risk. A young girl may want to have a cell phone, and then a gray-haired man like me will say, okay, I give you the cell phone, and then you tempt them. So, but yes, it works very well, and that's really one of the advantages in terms of the access. You, from all parts of the country, you can communicate if you have a cell phone. And we're trying just to link the two systems. Hopefully, we will be able to succeed.
Is it a free line? They can call in for free?
The toll-free line is the landline is free, but what we're trying to do is that there's only a single provider in Swaziland. It's a monopoly. So if that provider will donate time, like sort of like corporate social responsibility, then we will be able to get both sides covered and for free, so that we can get calls from all sides.
Okay, and we had a question let's take 1, 2, 3 questions on this side, and I think that's as much as we have time for.
Hi, Jama.
Hi, Mary.
Old friend. Mary Harvey with the Africa Bureau, and friend and colleague of Jama and a few others. Thank you. Again, it was really rich, and I probably missed some of the things that were presented, and look forward to reading it. This has really been something on our agenda, but not really. And Michal Avni and others who are working on it, kudos. I'm not sure if I caught this, but did you look at the role of drugs or alcoholism? It seems to recall that maybe the rate of alcoholism in Swaziland or drugs in other countries are sort of underlying areas that might impact, the rates of sexual violence. I'm not sure, but I thought that would be something important perhaps to look at or discuss. Also, I was just wondering about what are the percentages of the population of girls in schools, because you said I think that one was pretty low between school teachers and kids and kids. So I just wondered if it's a proportionate to what the population of the girl child is. I support and hope that we are able to raise funds to look at the issue of boys. And speaking of raising funds, I was wondering, Jama, what is the thoughts of getting other UNICEF missions in countries where we have some dear colleagues, maybe Nigeria, Suomi Sakai, maybe that's not the place, or DRC, to sort of find the funds to be able to, if necessary, either duplicate the studies or to utilize some of the findings that you have and the ways forward and what you're doing in Swaziland to change policies, norms, and procedures throughout some critical countries, Liberia, DRC, wherever in Africa or elsewhere in the world. And the last statement in terms of thinking of UNICEF and advocacy and others, what we're recognizing more and more, and not that I want an earmark from Congress, and not for non-communicable diseases, but mental health. I mean, it cuts across everything, and I think the only group that has some funding for mental health might be the HIV/AIDS. But besides sexual violence, there's so much more that needs to be done, I think, and we recognize we just don't have any resources to do that. So what is it on the advocacy agenda of others who can advocate to Congress and other groups to really look at this issue of mental health?
And here with Diana.
Hi, Diana Prieto, USAID Office of HIV/AIDS. I work on gender primarily, and thank you very much for your very informative and thought-provoking presentations. This is mostly, I think, a question for Jim about, I think you mentioned briefly at the beginning, an initiative that I think was launched very recently in collaboration, CDC, with various UN agencies and the Clinton Foundation, I believe. Mm-hmm. I was wondering if you could just provide a little bit more information about what that will entail. Sure.
Okay, and one last question here. Just pass up the microphone.
My name is Upala Devi. I am the UNFPA Gender-Based Violence Advisor. And thank you, Jim. And thank you to all of you for such a wonderful presentation. In a way, I'm quite familiar with this initiative, having now the opportunity of serving on the steering committee of the initiative as it's been rolled out in 4 pilot countries globally. But I just had two queries for Jama. More importantly, because as part of the UN system, we need to be on track as we roll out the initiative in these 4 countries that we've identified. The first is that you talked about the Deputy Prime Minister's office taking on the key agency role in rolling the process along the ground as it moves along. My question is that is there a steering committee consisting of UN agencies, civil society organizations, and other key ministries that are responsible for technically guiding the process, though it's a part and parcel of the Deputy Prime Minister's office, so to speak? And the second is, even within the UN system, has the study been able to lay the framework or the foundation for developing a one UN joint program on issues of violence based on a comparative advantage, based on mandate, or are we still working in silos, which is often the case? So, and I'm being candid here. Thank you.
Thank you. Okay, we're pretty low on time. If I could ask people just to keep short and sweet on responses to these really good questions.
So since it relates to the first 2 questions, and please help me if I add to this. But yes, this study really generated a lot of interest by UNICEF offices throughout Africa and East Asia, actually. Right now, we're doing this study in Tanzania as we sit here. And as Jama mentioned, Kenya's perhaps next in line. But this got the interest. It's a long story short. A fellow named Gary Cohen, who's on the UNICEF fund, is on a board member of the UNICEF fund and the CDC Foundation, is passionate about the relationship between child sexual abuse and HIV transmission. And he organized a steering committee through the auspices of the Clinton Global Initiative, which brought together UNFDP, UNAIDS, UNIFEM, UNICEF, CDC to raise funds to replicate this type of survey in other countries and associate that with a communication effort to change behavior, as well as a range of other responses along the lines that Jama talked about occurring in Swaziland in terms of strengthening human rights and prevention. So we're in the midst of working together to formulate the details of how we're going to proceed. But Bill Clinton actually announced this at the Clinton Global Initiative meeting, which was 2 or 3 weeks ago, which was very exciting. And we're very hopeful that we'll be able to raise funds to support this type of effort being carried out in other countries.
The one thing I would just add, and just in terms of an opportunity that's coming up, is the World Cup. And FIFA is actually doing a lot with UNICEF around drawing attention, particularly around HIV/AIDS. And this was news to me, but the World Cup website is the most trafficked website. The day that the brackets are announced, there's no website in the world ever that gets more hits than that day. And so one of the things that we've talked to folks about is, how do we get some messages around, focusing on men in particular, around changing norms, around sexual violence and sexual coercion, particularly as it relates to HIV. And could we, when we talk about partnerships, I did just want to get that in, that I think there are some incredible partnerships out there. And I think there's a lot with the CGI initiative, I think there's a lot of energy around that as well. So I'll add that.
Okay, thank you. I think, Mary, just to add to what Jim said, other countries will follow example. The example of Tanzania now is very good, and this is just the beginning. Maybe the ones in conflict will probably be a different cluster, but I'm quite confident that there would be some follow-up action. The question about the UN, the school dropout, the girls, the attendance of girls and boys in school is extremely high in Swaziland. It's almost universal. And in January, we will also likely to increase that percentage even higher, because for the very first time, the country will implement a new provision of the Constitution which says that all children must be able to attend school for free, primary school. So, but the problem is that the dropout rate and the repetition rate is high. And I think one of the factors, as Jim pointed out, that's contributing to even the dropout is also the pregnancy. So it's a vicious cycle. That is one issue that we need to deal with. The UN, I think the work that I mentioned the Deputy Prime Minister's office because of the matters related to children, but also it may be of interest for you to know that in Swaziland, the gender focal person in the government sits in the Deputy Prime Minister's office as well. So within that office, we have a number of key players. And it's really very, very interesting opportunity that we have in Swaziland. We haven't had in a long time. All of these happened in the last 2 years. How will the UN, is the UN working separately or together? I think when we were in the early stages of the planning of this study, the research team went to visit all the other agencies and they provided their inputs and ideas. And they have also, since the data has become available, they have used the information for the areas of programming that they have. 2 weeks ago, the UN organized a retreat for all the parliamentarians to review the draft bill on domestic violence and sexual offenses. And we did that as a UN. And that, again, is an indication of the effort that we're trying to make. But I think the level of interest that we see now, really at global level, didn't exist 2 years ago, if I remember, from the UN team. So now that there is that building up, I think I see the message will trickle down, and they will also reinforce what's happening at the country level. So I hope that we will be able to do. And I know that we're already getting some feelers from various offices, including UNAIDS, for us to think about it, ways in which we can work as a team on this area. But in the past, we were working with less information. But now that we have a better understanding of the problem and the magnitude of it, I think we can plan it better and strengthen the partnership.
Okay, well, I think we're out of time, unfortunately. But I thank everyone for their great questions, and I thank our three presenters. And as I mentioned, please hang around if you'd like some more. There's going to be 3 more presentations, again from Jama, from Deborah Bourne, who's in the back, and from Ian Askew, as we get into some related issues. But for all of you, thanks so much for coming, and please help me thank our presenters.